Great. Thanks so much, Chelsea. Again, today's webinar is using surveillance data from youth serving public systems. We're really excited that all of you could join us this afternoon or this morning, depending on where you're located. The Suicide Prevention Resource Center is supported from a grant by SAMHSA, but the views and opinions content expressed today do not necessarily reflect the views of SAMHSA, CMHS, or HHS. So along with myself, Julie Eben, Kristen Quinlan is going to be our other facilitator today, and she's going to be presenting a bunch of the material that you'll hear shortly. And so I'm just going to briefly review our agenda. So first we're going to identify how suicide surveillance data from 3 youth-serving systems, juvenile justice, child welfare, and public behavioral health, can enhance suicide prevention efforts. We're going to talk with you all to find out a little bit about needs and opportunities of accessing and using data from these systems. We're also going to try and find out a little bit more about future meetings, what else would be useful to you as you engage in data sharing from these different systems. Okay, so we're going to start off with a couple of polls. So first of all, which of the following systems do you currently have access to their suicide-related data? And please check all that apply. And as you are checking those boxes, if you want to go ahead and write into the chat which systems, your name, your state or tribal grant affiliation, and which systems you have access to, that will help us later for the discussion. So I see a number of people chatting in. Great. And it looks like a lot of folks have access to public behavioral health surveillance data. That's great. And then a few of you have access to juvenile justice and or child welfare data. Okay, great. All right, I see that South Central Foundation folks have access to their behavioral health, Connecticut, youth risk behavior, hospitalization data, poison control, okay. South Carolina has access to all 3, great. Yeah, you guys have a super system there. Okay, so for today's webinar, we're really going to be focusing on juvenile justice, child welfare, and public behavioral health systems. So it's great to hear what additional data you might have access to, but those are really the 3 systems that we're going to be focusing on. Okay, I see a few more folks typing in. And so for those of you who do have access, I'm curious where you are in the process, or even if you don't, where you are in the process of accessing or trying to access this data. So is this new? Is this something that you don't have yet but you're exploring, something you kind of have complete access to? Go ahead and just type that into the chat. We will definitely get more into this later, but right now we're just kind of getting a brief temperature of where you are all at. I see a bunch of folks typing. And if you don't have access to a particular system, maybe you can tell us whether you know whether or not your state system, that particular system, actually collects that data. So I see Minnesota that the juvenile justice has a survey similar to the YRBS. Wow, that's really interesting. They're working with them to try and link the data. Great. Really cool. Teresa McGinney in Kentucky, it looks like a local behavioral health survey, as well as some of the self-report studies. Great. Okay. Jessica Raymond, where are you located? What state and what state agency? Alaska. Okay, great. Oh, right, and you said that before. My apologies. There's a lot going on. Okay. Right, so concerns about lack of reliability. So we will definitely be getting into that more in a minute. So I'm going to go ahead, Chelsea, can you take us to our next polls, please? So if you do have access to this data, please answer the top poll. And if you don't have access, please answer the bottom poll. And if you have access to any of the systems, but not all of them, then just answer the top poll, please. So really the questions are, you know, how have you used the data, or how would you like to use the data? I see some more information in the chat. So Choctaw Nation is exploring this area and trying to do tribal-specific data for Choctaw Nation. That's great. Very interesting. Connecticut has access to death statistics. Okay. Very interesting. All right, I'll give folks just another minute or two to finish filling out the poll. It looks like a lot of you are using the information to enhance prevention planning, motivate for action, some quality improvement, a little bit less of program assessment, which makes sense. And then for those of you who don't yet have it, it looks like you would like to use it to enhance prevention and also focus your quality improvement. Okay, so interesting. In Indiana, there was looking at some common characteristics of folks in the community mental health system. Great, glad to hear that. Okay, so I'm going to turn it over to Kristen Quinlan now, who's going to go into the main meat of our presentation. So Kristen.
Thank you, Julie, and hello, everyone. As Julie mentioned, I'm Kristen Quinlan. I'm an epidemiologist with the Suicide Prevention Resource Center. So what I want to go over first is some of the background as to why we undertook this project, why we're concerned about surveillance data in juvenile justice, child welfare, and public behavioral health systems. First, we know that youth who touch these systems can have a large number of suicide-related risk factors. So this includes things like mental illness, substance use disorders, trauma histories. But even though we know that youth involved in these systems can be at higher than average risk for suicide, suicide prevention as a field hasn't historically known a lot about how to connect with these systems or about the availability or quality of suicide-related data from these systems. And there's lots of reasons for this. I think that these systems in juvenile justice and child welfare in particular are often overloaded, and they have a lot of competing and pressing other priorities. Sometimes these systems are worried about collecting or sharing information about suicide because they're worried that it's going to make them look bad, or maybe they don't have the resources to really fully address the issues should they find them in the data, and so they're afraid to either collect it at all or to publicize what they do collect or share what they do collect. And I think all of this is all the more reason why engaging with these systems is a big win for the suicide prevention community. If we can help juvenile justice, child welfare, and public behavioral health better document what's happening with regard to suicide in their systems, we can really better target our prevention efforts, and we can really reach those youth who are at the highest of risk. So in response to this issue and to better help the prevention community engage with juvenile justice, child welfare, and public behavioral health, SPRC developed two different resources. The first is the picture that you see there on the slide, Breaking Down Barriers. This is a report that we just released, and it's a full report that documents the challenges with getting and using data from these systems and some strategies on how to address the common barriers that we've identified. It offers a lot of different resources and links and some real-world stories from the field on what other states have tried in these systems and what seems to be working successfully. It also offers a couple of worksheets to guide you through the process of engaging with these systems from start to finish. So it's a very useful report, and it can be found on our SPRC website. The second is our suicide surveillance success stories, which you've likely all seen before. Again, these can be found on the SPRC website. These stories primarily focus on public behavioral health systems, and they talk about successes in obtaining and using data in this area. For the purposes of today, though, we're going to focus on that first resource. That's the resource that was just released. That's this Breaking Down Barriers report. Again, this is a full report on connecting with juvenile justice, child welfare, and public behavioral health. You may hear me throughout the presentation use the words youth serving state system today, only because it can be kind of a mouthful to say juvenile justice, child welfare, and public behavioral health every time. So we're actually going to kind of use a shorthand, and it will be youth serving state systems, just so we have a shared understanding of what we mean. So I want to give you a little bit of background on this report, and the report was intended when it was designed for Garrett Lee Smith grantees and their partners with the purpose of exploring the availability and utility of using suicide surveillance data from youth serving state systems. And as I said, it offers recommendations, resources, website links for working with surveillance data from these systems, organized by the different barriers that you might encounter. I saw earlier somebody mentioned the issue of availability of data quality, and so already I'm hearing some of the same themes that you'll hear us talk about today. So we'll go through some of the key barriers that we saw when working with, when talking to administrators from these systems, from talking to Garrett Lee Smith grantees, and we'll provide some resources along the way. So to generate info that we needed for the report, we used 3 different methods. The first was key informant interviews. We did about a dozen key informant interviews with administrators from these systems. Since we've already got those suicide surveillance success stories from the public behavioral health system, we really focused our key informant interviews on child welfare and juvenile justice systems. So we spoke to state administrators from those systems to get kind of their view of what the barriers might be to accessing and using suicide surveillance data from their systems. We also conducted a Garrett Lee Smith survey asking about your access to suicide surveillance data from these systems, some of the barriers that you've encountered, and your relevant TA needs as well. Finally, we reviewed archival data. This includes state Garrett Lee Smith grant proposals and SPRC's surveillance success stories, so we could gather some information about innovative partnerships and what's working out there in the field. So first I want to go through some of our findings with regard to existing resources. Using the methods we came up with some of these existing supports in suicide surveillance in specific systems. The first one I want to talk about is performance-based standards. This is a TA Center for Juvenile Justice, and it helps to create some consistency in collecting suicide-related information. It's a nonprofit organization. It offers a fee for service kind of programming. Not all states are using PBS, but some are. Those that are, sometimes are using it throughout the whole state juvenile justice system. In other states, it's in parts of the system, but not the full system. So I think when you speak with your juvenile justice system, it's a good question to ask them if they use this performance-based standard system. The benefit to it, as I mentioned, is that they do a nice job of defining suicide for juvenile justice systems and giving them a framework and a quantitative system in which to enter that kind of information. The other resource that we want to highlight is the Zero Suicide Initiative. Zero Suicide uses a system change approach to improving suicide care for folks at risk, particularly in public behavioral health systems. It takes a nice data-driven approach, so it's a really good model for accessing and using suicide-related data. So when you're thinking about public behavioral health systems, Zero Suicide is a nice resource. As you're all probably familiar with, there's also the National Center for Fatality Review and Prevention, Child Death Review Boards, Suicide Fatality Review Committees. These are systems, these are state teams that investigate suicide or child deaths, and they can serve as a resource for surveillance information about state systems where youth have been involved, in juvenile justice or child welfare or public behavioral health prior to death by suicide. They may have some of that information, so that's a good source as well. And then finally, there's the NVDRS system, the National Violent Death Reporting System. This is a surveillance system funded by CDC. Again, many of you likely are familiar with this already. And it can include some information on involuntary commitments, like placement in juvenile justice, foster care, or commitment to a psychiatric hospital. In particular, it has two variables related to involuntary commitment, both current and past 30-day commitment. So it's a source to go to find out if youth who die by suicide have been involved in juvenile justice, child welfare, or public behavioral health prior to their death. So as I mentioned, our report is really organized both in terms of these resources, but also in terms of the barriers that we noted when we did our key informant interviews and our GLS surveys. One of the first barriers that we noticed is this issue of availability. I think, the infrastructure for tracking suicide deaths often doesn't really exist in juvenile justice or child welfare systems. Oftentimes when we spoke with our key informants, we found that suicide-related data was collected in narrative form, usually in the form of incident reports. So if a youth died by suicide or had a suicide attempt while in custody, or it was recorded, it was coded in a incident report, and this is all narrative data. It's hard to prepare this data for sharing or for surveillance, particularly because we're talking about systems that are already overloaded. And so in order for them to clean the data appropriately of any identifiers in order to share it, it's really too time consuming to be practical, I think. Also, another thing we came across when we were talking to the administrators from these systems is that when sharing agreements happened with the prevention system, they were often informal. And this meant that if one person moved on, the sharing agreement collapsed. And so those were another type of availability issue that we noticed when going through, when talking to key informant administrators from these systems. And as I've mentioned before, there's this lack of system resources, and it's important. These are really busy systems, juvenile justice, child welfare, very, very busy systems, and preparing that narrative data and really, putting together a system for tracking suicide is very, very time consuming, and they have a lot of competing priorities and a lot to do. And so it's a challenge for them, and that creates some availability issues. So in our report itself, when you go to the SPRC website and download the full report, you'll see that availability is listed as a barrier, but underneath that barrier, we have all of these recommendations and resources listed below. Two of them are here on the slide, but there's many, many more in the report itself, along with some links that you can click on and resources and stories that you can take a look at. Some of the recommendations that we have when you encounter availability as a barrier is to have a vision of who's going to use the data, how it's going to be used, how data sharing might be sustained over time. You really want to take some time to understand the capacity of the existing data collection system and how you can fit suicide-related data into that system. You also want to reach some early agreement with partners on core issues related to data sharing. This includes the intended use of the data, transmission procedures, confidentiality assurances, other procedural and logistical issues, and these are really critically important for juvenile justice, child welfare, and public behavioral health, who really want to protect the, their clients. You also want to find ways to talk about how shared data is going to be mutually beneficial. Because we're dealing with very, very busy systems, we want juvenile justice, child welfare, and public behavioral health to understand the benefit of sharing their data with the prevention system. So, if you can come up with reasons and that it would be mutually beneficial for both for the prevention system and the juvenile justice or the youth serving system, that would be a big giant bonus. The other barrier that we came across when we were doing our key informant interviews and our GLS, our Garrett Lee Smith surveys, is this issue of data quality. Data quality can be an issue when working with youth serving systems. Our key informant administrators, when they spoke to us, talked about difficulties in defining suicide-related behavior. There were inconsistencies between states, there were inconsistencies within a single state, but there were also sometimes inconsistencies even within a single agency. So, for example, some of our key informant administrators spoke of individual staff differences in identifying what they did or didn't constitute as a suicide-related behavior. So those inconsistencies are really, present throughout a whole bunch of different levels. Inconsistent definitions, when combined with inconsistent reporting, can make things really, really challenging, even if we have some data sharing, agreements. There's also difficulty tracking youth across time and across systems, and so that's a problem as well. Again, these recommendations are laid out fully in our report itself, but you want to make sure that you consult with the youth serving state system, providing them with some information on creating common definitions for suicide-related behavior if you can, or helping them build suicide surveillance infrastructure. It's also helpful to enhance connections between existing suicide surveillance groups like Child Death Review and youth serving state systems like juvenile justice and child welfare. Trying to link those two systems up is very, very helpful. It might also be helpful to help youth serving systems access standard definitions like the World Health Organization definition for suicide or other industry identified definitions for suicide. So those are some specific recommendations that you might use when data quality is a barrier. That said, I'm going to turn it over to Julie so we can facilitate some discussion about this.
Great, thanks, Kristen. So I'm curious to hear, from the group here, it sounds like some people do have access to these systems, but maybe a lot of you do not. And I'm curious how availability issues have impacted your ability to plan with these systems or look at the systems. So go ahead and please either unmute yourself and speak aloud or type into the chat, whatever is easier for you. Melissa, do you want to go ahead and share what you're about to type out loud?
Oh, no, I had no idea you could see that. I was going to type. I was just going to say, from the health department's perspective, we see these as like epi investigations, which our commissioner and through statute we're allowed to sort of do. The problem is that the organizations that we're trying to work with have a different commissioner, different statute, different things underneath that they feel about data sharing. So it's so frustrating when we know what data we want, how we want to do it. We already have the methods already figured out and everything, but there's just a cultural clash as far as what data is used for. And just taking that time to educate everyone, and then you educate sort of your peer at the other organization, and then they have to educate their leadership, and then by that time there could be a new leader. So, I mean, nothing that was written up here, thankfully, was surprising. It validates our experience, but it's really frustrating when you want to use data to make prevention and there's bureaucracy in the way. So, nothing really bad.
Yeah, great. Thank you for that. That sounds extremely frustrating. I'm curious when you say, in terms of what data is used for. Does any of it have to do with, people being worried that it might be like viewed in a punitive way, or so kind of not good for the public-facing side of things?
I don't get that as much as I don't think we can share that with you. And then we try to educate them that this is an investigation and you can. And then it just falls on deaf ears. So then what we say is, well, we'll share our data with you, and then could you do the linkage and stuff like that? And then, but they don't have the EPI capacity.
Mm-hmm.
They might have a data analyst who's used to their data system and is excellent, but not used to sort of looking at it with an EPI lens. So that's more what I hear than it will look bad.
Great, thank you. Who else has an experience that you want to share related to data availability or data quality? Casey, you were mentioning earlier some concerns about quality.
Yes, and excuse me, here in South Carolina, we are very fortunate to have access to data. But the issue is we actually receive some data from DSS and DJJ, and just from our experiences on the ground and looking at the literature, and actually what was reported was quite a bit lower, obviously, than what we had expected. So, we had done some stakeholder interviews, and unfortunately there's just not consistent screening, assessments, and referrals going on in these systems. So if that's not happening, obviously the data is not going to be reliable. So it's been really frustrating because we are actually able to link, suicide attempt rates and death rates to these systems, and even with our behavioral health system, we're actually able to follow individuals through systems. But so we'd have a lot of potential to do a lot with that data and learn a lot, but if it's not reliable, you can't do a lot with it.
Thank you. That's, very interesting. Do you want to say anything about your magic ability to access all of the data? Because I suspect other folks might be wondering.
Sure. So we are extremely fortunate, and we realize not everyone has a system like we do. That back in the 1990s, it was actually mandated by our legislators here in South Carolina that a lot of state agencies, including our behavioral health, our DSS, DJJ, vital statistics, and actually all our hospital claims data be entered into this data warehouse, basically, and it's managed by a state agency. We work very closely with them. We are required to get letters of support from each state agency head, and actually did not have a lot of problem with that, just because one of our evaluation team members has a lot of connections, so that was helpful. So actually we've been able to access data pretty easily, and I know that's just not the norm. So that's why it's a little frustrating, because we know we could do a lot with the data and add a lot to the field.
Right.
Yeah. So.
Yeah. And you guys have a law that was passed that enabled that data warehouse to exist.
Yeah,
Just
I mean,
FYI for the other states.
Yeah, I mean, and actually we've applied for 2 grants in the last 6 months to kind of mine that data, because there are agencies that do have reliable data that we could at least use. And our particular GLS grant is actually housed within our public behavioral health department, and I think we're one of the few behavioral health departments that still give direct client services. So we're able to actually get a lot of that data as well.
Great, thank you.
Mm-hmm.
Lori asked in the chat if you can cite the legislation in South Carolina so they can reference it.
Ooh, yeah, I'll have to look that up. It's actually housed in the Revenue and Fiscal Affairs office, and all that's on their website. So I'll be happy to get that to everyone.
Great. Was somebody else going to add a comment or question? Maybe Candace? No.
Yes.
Okay.
Can you hear me? I was wondering if anyone has linked with higher education to address the high intensity it is to withdraw data from paper records, for instance, or even electronic records if it's in text form, as you mentioned. Seems like having a student learn about evaluation and surveillance in some subjects would be a nice project. And I imagine the supervision issue might be tougher because of everybody's busy schedules, but I was wondering if anyone has explored that.
That's a great question, Candace. So has anybody been able to tap into, maybe graduate students or even, more advanced undergraduate students to help with some of that, the issue around narrative data or just paper forms, et cetera? And while people are mulling over that question, I see, Laura, you were putting in the chat around Indiana's VDRS and the Child Fatality Review, frustratingly both sitting in the same department but not being able to share data. And I know a little bit about the backstory, but Laura, do you want to share that a little bit more about why that is?
Yeah, I saw a Kelly Cunningham on the line. Is that Kelly Cunningham from Indiana by chance? Because she could really address this.
No, from Massachusetts.
Okay. Yeah, so, I mean, it is kind of frustrating. We have a really nice violent death reporting system that came on board in 2015, and the epidemiologist with it has really done lots with it. So they have individual agreements with all of, not all, but almost all of the county coroners in Indiana and law enforcement agencies. Well, the data that the violent death reporting system obtains with those critical incident reports and other data can't be shared with Child Fatality Review, and the violent death reporting system isn't wanting to change their data sharing agreement so that it would include Child Fatality Review, in fear that those agencies and coroners would then say, oh no, well then we're not going to share any data with anybody. So again, it's this almost this fear of who's going to see what. And that goes right in line with the stigma, now that death data is public record for us. There's definitely a sense of some coroners saying, well, I'm not going to identify death by suicide because then I know somebody down the line could possibly see this data or purchase this data. And then there's this whole community stigma and around a death by suicide. So that's very much a cultural thing, I think.
Thanks, Lori. And it's not so much that the current MOUs exclude the Child Fatality Review, purposefully. They just didn't include them, and so,
Correct.
Now they're done and they can't go back and sort of redo. Thanks. Michelle from South Central Foundation, or anyone from South Central Foundation, I'm wondering if you wanted to say anything about your access to the behavioral health data there and what maybe made that possible.
This is Michelle. I really don't know what data to share. I really wish our supervisor was here right now. So if anybody else from South Central has more knowledge, feel free to share. You said my name, but I'm thinking.
Okay, yeah, sorry to put you on the spot in particular.
When I need to, so I'm like, oh, I don't have anything to really say.
Okay. Anyone else from South Central Foundation?
Hi, this is Jessica. So we do have the Garrett Lee Smith grant as well. And so some of the data, is data that is shared through the GLS grant. And I know that for sure we have open access to, and that's how we have access. And the state of Alaska has made some pretty significant promises to the people of Alaska to affect change in the area of suicide, since our rates of suicide are just so astronomically high. And so that has led to the state being more open to sharing and more transparent in the data that it collects from public health and DOJ and DJJ. So I think that's where the majority of our data access comes from, just from the state. Our governor actually recognized this as an epidemic here in Alaska and something that they're begging for involvement from different agencies in.
Great, thank you. And do you know whether you had to kind of create different, sort of individual data sharing agreements with DJJ and or with the public behavioral health system, or was that able to be shared without that kind of formal agreement?
As far as I know, there isn't a formal agreement required.
Okay, thank you. Amy Painter, I see, put into the chat if anyone can speak to whether NVDRS or other data sources that exist through the state includes information on tribal affiliation or even just Alaska Native American Indian designation. Okay, so Melissa in Minnesota said that when that's available, they can, identify the tribal affiliation. So, Melissa, when that's available through the death record, is that fair to say?
Available through any of our number of source data, whether it's the LE report, the autopsy, field investigation, obituary, death certificate. We access so many files. It's just a matter of whether it was known and noted.
Okay, great, thank you. So any other questions or anything anyone wants to share on this point before we sort of go to our next area and talk a little bit about the next barrier that we found and some recommendations for overcoming it? Okay, well, not hearing anything, I'm going to move on. So before we go to our next barrier, I also wanted to point out that the new report has an appendix with a packet of worksheets that we've also put up separately on our website in case you want to just download the worksheets in electronic form to be able to type into them. But there are 4 worksheets, and the first one is really for you to use before connecting with a partner agency to talk about, the possibility of sharing data. And so things like, what existing relationships you have, what linkages, who needs to be brought on board, developing a vision of your data-related needs, and some other details in there, thinking about what the benefits are to your partner to get their buy-in. The second worksheet looks at, here are some things to discuss during your initial meeting and some things to try and find out. And the third worksheet is, let's say, they're on board, yes, hooray, getting into a little bit more of the details, logistics, uses of data, are you both on the same page, et cetera. And then the fourth worksheet is an opportunity for you to think about your technical assistance needs in this area as Garrett Lee Smith grantees. All right, so I'm going to turn it back over to Kristen to talk a little bit about the next barrier.
Yeah, first I just want to thank everyone for a really interesting discussion. I think a lot of really good ideas came out of that discussion. I heard leveraging connections of staff, like having an evaluator who is well connected and really capitalizing on that. I heard educating your partners on the benefits of data sharing, offering to share your own data and having them do the match. I heard having a student project, taking advantage of sort of student resources, university partnerships. And I also heard having buy-in from the highest levels, like the governor, or having a mandate. All of that can help with issues of availability and data quality. And so those were some really interesting and great ideas that we heard on the phone, so I really appreciate that. So to talk briefly about our next barrier, as you recall, in the report itself, we've organized what we heard by barriers, and one of the barriers that we identified is this issue of, efforts not being system-wide. When prevention efforts aren't system-wide, surveillance data is not going to be the best source, particularly for measuring impact. So if you've only done work with part of a system, you can't really expect to see system-level change. And so if you want to use surveillance data for measuring impact, you have to have adequate dose and reach. And so just kind of keeping that issue in mind when you're thinking about using surveillance data as an outcome measure for evaluating a program or a prevention effort. Some of the recommendations that we have in our report for dealing with this problem are to make sure you understand what else is happening in your system aside from your own interventions. So understanding that other prevention efforts might be happening. Maybe there's more comprehensive prevention happening than you originally thought. And so having an idea of what else is happening can be really useful for that, and also for evaluation more generally. I also think it's useful to consider using smaller targeted program evaluations to demonstrate impact. The cool thing about program evaluations is that you can design your own survey and your own measures, your own questions, and tailor it according to the program that you did, as opposed to using existing surveillance data, which may or may not kind of correspond so well to your prevention efforts. And so that said, we're actually ready to share our story again, so I'm going to turn that over to Julie.
Great, thanks, Kristen. So it seems like there aren't a lot of folks who are involved with the systems in terms of the getting surveillance data. I'm curious to hear who might be involved with any of these three systems. In doing systems change work and doing suicide prevention work in the systems. So whether that's the whole system or part of the system, is anybody here doing zero suicide in public mental health or public behavioral health, for example?
Hey, Julie, this is Casey.
Yes. Mm-hmm.
Okay, yes, we here in South Carolina, we are doing some zero suicide pilots within our Department of Mental Health. We have 17 community mental health systems or clinics across the state, and right now we are working with 7, and of course we want to expand that year by year. And so we'll be pulling DMH data as we work through that to kind of see where the changes are happening.
That's great. And so it sounds like right now it's more of a pilot, you said, but I'm familiar with the grant. I think you guys are in all of the, you're implementing the systems or the changes across the system, correct?
That's correct. Yeah, and the biggest barrier has been getting like the Columbia screener and the safety plan embedded within the EMR, which has greatly affected our ability to track progress. But as far as our clinics are concerned, we have had great response. People are wanting to be a part of this. And once those things are embedded within the system, the protocols, it's actually for every DMH patient. It's not just for the 10 to 24-year-olds. So we're really hopeful that once everything gets up and running, it really will have an impact across the system.
That's great. And what kind of how would you use that EMR data, or sort of what kind of evaluation are you thinking about, or sort of planning or quality improvement?
Sure. So we're going to try every 6 months. We're working with our IT folks to look at pulling, how many screenings were done monthly, how many safety plans were developed, how many folks had lethal means counseling, and then because we can link to hospital and vital stats data, we can also look at, folks that participated in the Zero Suicide activities and were DMH patients, how many attempted suicide or died by suicide as well. And we're going to be reporting those back to the pilot site, that data.
Great. Great. I see that Agnes Green is typing into the chat box. Agnes, do you want to share your thoughts aloud? Or you can keep typing into the chat box. That's fine. I know sometimes if you're in a noisier area or something, it can be a little bit tricky. So other folks who might be working with part of a system to do some suicide prevention work in public behavioral health or juvenile justice or child welfare, can you say a little bit about what you're doing and what data you have access to, if any? Liz, in Missouri, it sounded like maybe you have access to data from some local medical examiners, and I'm curious whether, how you might be using that to look at some of the work that you're doing in your community mental health centers.
Yeah, well, we we're doing work in 5 counties in the Kansas City area. And so I've contacted the medical examiner who covers 4 of those counties, and she's provided me with the data having to do with the age range of the youth that we're serving, and then residential statistics, all the things that you can get off of a death certificate. So she's agreed to provide the data to us yearly, really in advance of from when we can get it at the state level. So I found that, and she's also provided data back from, I think it was 2011, so we can look at any trends over time.
Great. Great, thank you. So Agnes typed into the chat box that at South Central Foundation they're using the GLS grant to connect youth to services like behavioral health consultants. And so Agnes, can you say a little bit about where the youth are coming from, and are they connected to any of these 3 systems, or is this broader?
So I work with Covenant House here in Alaska through South Central Foundation, and we collect data through SurveyMonkey, and the people that we do survey on, we ask them the question, are you suicidal? just get right to the point, and then most of the time they are not, thank God, but even if they're not, if they're feeling sad and depressed, we try to connect them with behavioral health consultant or any other services, and through that they go, they may be connected to more like in-depth services such as more counseling, which are like an hour long and so forth, maybe medication management and stuff like that. I hope that answers your question.
Okay. Okay, great. And where are you finding these youth that you're doing the SurveyMonkey with? I might have missed that, sorry.
So this is Michelle. Agnes is, I think she hung up accidentally.
Oh no,
but we're in the
okay.
same office area. So to just kind of give you guys more information, South Central Foundation is a tribal organization. It's also part of the Alaska Native Medical Center, the hospital here. So our beneficiaries own their hospital. They own their care. So with the GLS grant, when she said she works at Covenant House is a runaway shelter here in Alaska. So basically, Agnes works with our youth where, you know, she gets to ask, you know, what's going on with them and if they're suicidal or not. And then depending on what resources they need, then she brings them back to our hospital to get them connected to whatever services. I mean, we do dental, vision, behavioral health, you know, anything that they're actually needing. And then we also do a lot of resource referral. So that's the GLS grant and what they're doing for the youth. Our program here at South Central Foundation is called Denali Yeats, and we work with the adults that are actively suicidal. So we do direct care. And we do a lot of cultural activities in both positions because, you know, we want to do all the resiliency factors. So earlier when you asked me, like, what data are we collecting, again, we do more of the direct service, and we know that the GLS grant's collecting different data, but unless you're speaking to one of those staff, I couldn't answer.
Okay. No worries. No worries at all.
More. She's still trying to get back there.
Yeah, no, thanks for delving into that a little bit more.
Yeah.
Does anybody have any other comments or questions on this section before we move on to the next one? All right, so I'm going to turn it back over to Kristen to go through the next section.
Okay, so this next barrier is probably one that many of you are familiar with and have encountered before. Working with small numbers is something that came up for Garrett Lee Smith grantees in our survey, and also with our key informants in the juvenile justice and child welfare systems. Because youth serving state systems generally have small populations and relatively few deaths by suicide, suicide data from these systems, even if you're working with a larger system, can be too small to analyze for any kind of meaningful change. It's really hard to determine whether or not the changes that you see over time are happening because of your prevention efforts or if they're just chance fluctuations. So that's one issue, is sort of this kind of statistical issue and this outcome issue. But there's also the issue of unintentional personal identifiers that can be a concern when you're working with small numbers. So because suicide's not common, it becomes even less common when you're looking at a sliver of the entire population, like youth and juvenile justice systems. There might be only a handful of deaths by suicide in a youth serving system like this, even in a large state. So if you share demographic information, you might have some unintended identifiers And so it's definitely a concern for, the partners like juvenile justice or child welfare or public behavioral health, because they want to be careful about those kinds of, the release of that kind of information. Some trends for, or some recommendations for interpreting trends with small n's. You might consider using alternative measures to triangulate your findings. This could include things like key informant interviews, focus groups, qualitative methods that really help support and kind of beef up any small numbers that you see. When it's appropriate, so when the data are measured sort of consistently over time, there's also the possibility of just aggregating them together and speaking to, a period of time, a bigger period of time rather than just a year, for example. So speaking about like a 3-year period or, looking at those kinds of intervals. If you combine the data points over time, you can increase the number of suicide events, and then you can really have a better sense of where your trend is going. It's also important to use, confidence intervals and really acknowledge the impact of that random fluctuation. Small numbers can also be useful when thinking about quality improvement efforts. So, taking a single, case and really delving into, the circumstances and the context around it can be very, very useful and have its own utility as well. And with that said, I want to turn it back to Julie so we can talk about, what you've done with small numbers.
Yeah, thanks, Kristen. And I think that this, is particularly important around death and attempt data, and it may not be just from these particular systems. So, I'm curious to hear from folks who may be dealing with small numbers even from broader areas, how that's impacted your use of surveillance data. If you're looking at deaths or if you're looking at attempts where maybe it's a smaller area, how you've kind of managed that, given that it may be a small number.
Hi, this is Teresa McGeaney from Kentucky. I am an epidemiologist and on the evaluation team.
Hey, Teresa.
And something that we had, from 2014 to 2015, we saw a large increase in suicide deaths among youth, being in Kentucky being defined as 10 to 18-year-olds, and the figure about doubled from 2014 to 2015, but we did have the issue of small numbers. So it doubled, I think, from fewer than 20 to maybe in the mid-30s in 1 year's time. And then we had heard some preliminary data that sounded like it was going to be on track to further increase the following year. Thankfully, it didn't. But something that we did to explore this increase and see, to what degree, there was something that we really needed to take. To what degree we needed to take action. So we pulled together kind of an ad hoc work group and tried to gather as many data holders as we could. So we had folks at the Kentucky Injury Prevention and Research Center. They're a bona fide agent of the Department of Public Health in state government. So they had access to hospitalization data as well as the vital statistics, fatality data. We also got the violent death reporting system folks in the room, child fatality review, poison control, and some the YRBS folks. And myself, I've got access to another behavioral health system survey in Kentucky. So we gathered everybody in a room and met regularly and looked at kind of the data from various perspectives, and what we saw was pretty much a steady increase in attempts, both in the poison control data set and the hospitalizations, and that did kind of appear to coincide with the mortality data that we were seeing. And then we finally got 2016 mortality data, and we didn't see a further increase. So, but we did look at means and demographic and geographic breakdowns as much as we could, but it really did help us to borrow from other data sets to look at morbidity rather than just mortality to figure out what was going on in the problem.
Great, thank you. Sounds like you were really kind of coming at it from a number of different angles, sort of like we were talking about triangulating the data. So that's really helpful to hear how you were able to kind of, enhance those numbers to be able to look at it more comprehensively. Other folks who maybe were working with small numbers and how you've gotten around that, or any tools or resources that you found to be helpful. I see someone typing into the chat, and I don't want to butcher your name, so can you maybe speak aloud and introduce yourself and tell us a little bit about what you've done? Oh, I see, combining multiple years of data to get a smoother average. Yeah, great ideas. Other folks? All right, well, I'm going to move us into our next slide because this is sort of moving us into a broader discussion here, so we can kind of continue with that theme from before, but take it a little bit further. So I'm curious to share what other barriers you've encountered in trying to get access to data from again, sort of back to the youth-serving public systems. And the reason why we keep focusing on that is just because we know that there are some really high-risk youth in those systems, and because they're somewhat of closed systems as well, it may be easier to be able to look at change over time. So I'm curious if folks have other things that they want to share about that. And then I will see also in the report there's one more section that covers a little bit about the systems separately, but we've covered most of it already, so we won't break that out separately and sort of repeat ourselves. So in addition to these systems, it sounds like, maybe folks are just starting to think about accessing data from those systems, and that this is still sort of an area where people are maybe delving in a little bit more. But I guess I also wanted to see, Colby, I hope you don't mind me putting you on the spot. I know that zero suicide is still a little bit new for you folks, but I'm wondering if you wanted to say anything about how you're accessing data as part of your zero suicide efforts, if that is something that you're at that stage yet.
So when it comes to state data, not really.
Right, not necessarily state data, but yeah.
Okay. When it comes to the data that we get from our tribes, we really just have to figure out if their systems can run certain reports. And we continually work on that. We do have one of our sites that their medical clinic and their behavioral health clinic, they have the same EHR system, but their scheduling system is not the same. So when you go to run a report, say they're trying to put how many people have a positive PHQ-9 score, and then also are high risk on the Columbia, did they receive follow-up in a timely manner, or have they continually canceled their appointments, or what's going on in the follow-up realm. And because the scheduling system does not connect to those two systems, they have to do that manually. So they have to run the report, who has the positive, who has the high risk, and then they'd have to look at that report and compare it to the scheduling system. So that takes a long time. So that's something that thinking about, okay, should we try to see how much it would cost to then add the scheduling system for both so that everybody would be on the same page. Another thing that we've ran into is we've had sites, they're not specifically connected to our Garrett Lee Smith dollars where they receive, a good chunk of money to help with their implementation efforts, but they're trying to do it on their own. And their EHR system does not actually have an alert built into, any alerts built into it to flag when there's a patient that's on the suicide care pathway. So that's been something that's been difficult for them, and trying to figure out if their EHR group will build that in and why it's not already there. And, they've spent a lot of money on this EHR, and it's just not ending up working out. But that's for other things, too. That's even for chronic conditions medically. So
that sounds very frustrating.
Yeah, and these are things that you don't know that you really need until you start to do, behavioral health integration, you start to do cancer navigator projects, just whatever you're doing where you're needing to flag your patients. And then we have another site that running the reports, they can run different reports to find data, as in our which providers are actually asking the questions and doing a really good job at connecting with the behavioral health group. But there's so many that the follow-up is difficult. So, and this is not, attempts and suicide data, obviously. This is more screening data. But we also don't have connections with coroner's offices and larger hospitals, and they don't have the staff to look at every single patient that's no longer, or former patient, to find out why they're not there. Did they die? Did they have an attempt? And so we have that lack within the attempt and suicide data. But that's something that we're hoping to supplement with other dollars that we have at our epidemiology center to maybe go out and do chart audits. We are not confirmed on any of that, but that's what we're hoping, is we can find some money to do better baseline, because these are things that you have to be so connected to all the different possibilities of this person dying and the death certificates, and what's on the death certificate, is that correct? We'd have to talk to the coroner, and all of these other things, that it's just a really long process.
Yeah, no, it sounds it, and it sounds like you're making some good headway, so good luck, and thank you for sharing that.
Yes, so please ask SAMHSA to have another 5-year round of funding. We're almost done.
Okay, will do. I'm wondering, Jill King, if I could put you on the spot and ask a little bit about how you, if you were working in your public behavioral health system as part of your, I think it was an NSSP grant, or, was it in other settings, and, how you access the data for that.
Hi, can you hear me?
Yes.
Okay, good. Yeah. We formerly had an NSSP grant, and we currently have the Zero Suicide grant. And we collected, like process data, numbers screened, numbers that received a safety plan, numbers that received structured follow-up. But then we also looked at some county level data. But like some other people on this call, I can't speak too much to it because we're still in the process of figuring out what it all looks like, and our evaluator isn't on the call. So I'm sorry for not being able to share some more specific information.
No, that's okay. Thank you. Thanks for chiming in with that. Celeste from Kentucky, from Connecticut. I'm wondering if you could say a little bit about what you're how you're using your violent death reporting system data, how that's going. I think you're still, maybe you actually are no longer on the call. Oh, that's sad. Is there anyone else from Connecticut who is on who might be able to speak to that? All right, well, we were perhaps too late for that angle. But Melissa, let me, in Minnesota, let me go back to you for a second. Can you say a little bit about your juvenile justice survey?
Yeah, so we in Minnesota, rather than using the YRBS, we use the Minnesota State Student Survey, which has a lot of the similar questions, so we can compare nationally, but allows us more flexibility in sort of adding additional questions and such. And so the Minnesota Student Survey is also administered by our juvenile justice facilities. And I'm not sure if it's a census or a sampling, but there's a report then that's distributed, and it's fascinating, the results, and very sad, the results, but it definitely speaks to the need. And I can find the link and put it in the comments if people want to see and learn more about it.
Sure, that would be great. Thank you. Does anyone else have a similar process where they have a local, behavioral health survey that is also in their juvenile justice use? And Melissa, Kristen was asking whether your juvenile justice system survey is an annual survey.
No, our survey is administered for the Minnesota Student Survey every 3 years.
Great, thank you. And I'm not sure if it was Teresa or someone else from Kentucky that chatted in before that there's a local behavioral health survey that you're working with along with vital statistics.
Yes, we have a survey that was initially funded. It was primarily a substance use surveillance survey when it was initially funded, and it's administered every other year. It's anonymous, but it is huge because we don't employ a sampling methodology. We invite every single school district across the state to participate, and then participating school districts, we invite every single student in 6th, 8th, 10th, and 12th grades to take a survey. And we've recently added, I think in 2014 was the first time we added questions on suicidal ideation and behaviors. So it's not connected to vital statistics. It's out of the Department of Behavioral Health. So unfortunately not connected to any other systems, so we can't link data, but we can. It's very useful in terms of getting regional, a regional snapshot of what's going on, or to better understand the etiology of, suicidal ideation or suicidal behaviors.
Great, thank you. What other resources do folks have that they'd like to share, either connected to, those 3 systems that we mentioned, or more broadly? And actually, Pennsylvania folks, Perry or Rose, it looks like you guys might have dropped off. If you're still on the call, I would love for you to talk a little bit about what's happening with your child death review. No, I think that they had to go. Other resources that folks want to share in terms of your surveillance work? Or if not resources, we are also really curious to hear, as you go forward with your attempts to access data, especially from the systems that we mentioned, what kinds of technical assistance supports would be helpful. Things about working with narrative data, about uniform definitions, about how to look at, what if you're in a sort of mixed public-private system, other desires. Casey, I see you typing, and I'm going to call you out if you want to share your thoughts aloud.
Sure. Wasn't able to type it out before it called on me. One thing we've realized with our suicide attempt data is, I don't know if this was a universal date, but in October 2015 in South Carolina, we all our hospitals switched from the ICD-9 to ICD-10 coding system. And we really try to dig into the data or the literature to see, you know, what other folks have done. But we do anticipate this is going to affect our data quality. So I was just wondering if anyone else has had any issues or any epiphanies about it.
So has anybody else had any solutions to the ICD-9, ICD-10 switchover and the hurdle that represents? I know we did speak with you a little bit about that separately, Casey, so I don't want people to walk away feeling like we're just, you know, hanging you out to dry. But it would be great to hear from others, too, if they have ideas. And Melissa, thank you for posting that in the chat about the MSS data reports. So there's, you know, a bunch of folks on the call that we haven't heard from at all, and wondering if you have other resources or solutions that you'd like to share or other TA needs. And I will also say that we have a number of success story vignettes within the report that we hope you will check out, including from South Carolina, including from Ohio, and I see at least one person from Ohio on this call. So, you know, other success stories in there as well. So thank you. We really appreciate those. Shauna, do you want to say anything about how you're exploring collecting your own surveillance data within Choctaw Nation? And Shauna, if you're still here, you might be on mute. All right, well, we've got some folks may have left the call early. Just curious to maybe hear from a couple more folks. Anything you want to share about where you are in accessing your surveillance data or how that's going? Barry Fawcett, I don't know if, I see you're still logged on. I don't know if your audio piece is still connected or not. People are feeling very reticent to talk this afternoon. What about any of the Arkansas folks? All right. Well, it sounds like maybe people are still kind of taking in all of this information, digesting, and figuring things out. Give a last call, Massachusetts. You guys want to pipe in with anything here?
Hi, Julie. It's Kelly. Hi.
Hi.
The only thing that really kind of popped in my mind as we were talking about all this is one of the things that we're doing with the GLS is we have 2 hospital systems, and one of the correlations we had not been able to really determine was if somebody had died by suicide, when was the last time they had been in that hospital system? So we were able to gather our vital records into a disk to give to the hospitals. And we've started with the baseline of 2014. And actually in one of our hospitals, we did get a hit, I think 2 hits for youth, and then they did it across their entire system. So they did get a couple of hits from adults.
which they've found very interesting and helps them to better look at, now that they've implemented universal screening, to see if this is something that they can help rectify in the future. So we're getting ready to give them the next year's data, which is 2015, and seeing if we're going to see anything else coming up through that.
Mm-hmm. Great. And so I think these are not part of the public system necessarily, but it's great to hear, more broadly about how you're working with that data
Right.
for quality improvement purposes. That's great.
Exactly.
Thank you. Does anybody else have any stories they want to share or any connections, successes that people have had with connecting with their child death review boards? I see Jessica raised your hand. Go ahead, Jessica.
Oh, I raised it before the final part of that question.
Sorry.
My thought was based on something I heard a little bit before that. So I'm not sure how standardized it is across the U.S. That hospitals or public health agencies have a screening system for mental health or suicidal ideation, but that's something that we use and then track responses to. So when anyone is seen for any reason, whether it's behavioral health or physical health, they're given a screening, and I think it's like 4 questions, and one of those questions relates directly to depression and or suicidal ideation, and if they respond positively to that, if they say that they have been experiencing depression or suicidal ideation, and the phrasing is a little bit more vague than that. It's not quite that direct, but then there's an immediate response, like that triggers things in our system, our public health system, for a clinician to respond every single time immediately. There's no waiting. There's no it gets kicked off to a referral that's responded 2 days or weeks later. It's like an immediate thing, and I think that's a huge piece of data collection for us, is that we can see when those screeners are responded to in a certain way, and then there is a very specific clinical response that takes place that can be tracked in our system, and we can see how effective those responses are and where most of those yes answers end up.
Mm-hmm. Great. So it's you're able to really use that data for quality improvement efforts. It sounds like. Are you able to, you mentioned you're able to look at it over time. Are you able to look at system improvement based on like a snapshot over time of suicidal ideation?
Yeah, I think that's something that we can see, and part of that is educating everyone on how to respond to that, and that's so our agency, for example, has responded by realizing that everyone in every type of position, not just behavioral health, needs to have basic awareness of how to appropriately respond to suicidal ideation in a patient. And so, we do the Living Works curriculums. We have Safe Talk and Assist trainers here on campus, and our entire staff, not only behavioral health, but everyone is supposed to be trained in Safe Talk, which is like just the initial, I don't know how familiar everyone is with Safe Talk, but just that initial entry level information on how to appropriately respond to suicidal ideation and ask directly about suicide. And so that's something that we gleaned from that data, was that, we don't have, across the board appropriate responses to this, and that's something that we need.
Great, thank you. So I realize we're almost at the end of our webinar today, so I just want to briefly touch on some resources. Chelsea, if you could go to the present, there you go. You read my mind. So this report, as I mentioned, is on our website, and the URL is there, but we will also make sure you have it after the webinar. And then also we're anticipating, hopefully at some point in the spring, that we are going to also be putting out a report on surveillance strategies in American Indian and Alaskan Native communities. So definitely look for that. And then we have links to our state-specific surveillance success stories, but we also do have some tribal surveillance success stories as well. And please do feel free to follow up with us about technical assistance needs, and we're happy to, talk more with you and your prevention specialists after this, to follow up after you've had a chance to kind of, take some of this information in. If you have questions about the report in particular, or about other surveillance technical assistance needs, we would happily help you out with those. So thank you so much, Kristen. Thank you to everybody for attending and sharing your experiences and your ideas. We really appreciate it. It's great to hear everything that folks are doing. Have a great rest of your afternoon. Take care, everyone, or rest of your morning.